Welcome to a deep dive into something we all face, managing patients with cardiac implantable electronic devices, or CIEDs. This explainer is really designed to be your practical guide for handling these complex and sometimes tricky scenarios with a whole lot more confidence, all based on the latest evidence.
Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. All right, let's jump right in.
So, here's our game plan for today. First, we've got to get the basics down, the language, the logic behind how these devices actually think. Then, we'll walk through the official playbook, the ASA protocol, step by step. And finally, the fun part, we'll apply all that knowledge to two really interesting real-world case studies to see how it all comes together when it really counts.
Okay, let's get into our first section. Look, before we can even think about managing these patients safely, we have to speak their language, the language of their devices. Honestly, getting a solid handle on these fundamentals isn't just nice to know, it's absolutely non-negotiable for patient safety.
So, what exactly is a CIED? Well, you can think of it as an umbrella term. It covers any device we implant to manage the heart's rhythm or function. This includes pacemakers for when the heart is too slow, ICDs for when it's dangerously fast, and even CRT devices for certain types of heart failure. And getting the management of these wrong in our world, well, it's not a small thing. We're talking about serious, severe outcomes. Things like profound hypotension, life-threatening arrhythmias, and even direct damage to the heart muscle.
Now, this might look a little intimidating at first, but it's actually a super logical system for understanding pacemakers. It's a 5-letter code. The first letter tells you which chamber gets paced. The second tells you which chamber it's listening to or sensing. The third letter is key. It's the response. Does it inhibit its pacing when it senses a native beat, or is it triggered by one? The fourth tells you if it's rate responsive. Can it speed up when the patient exercises? And the fifth is about multi-site pacing. So if you see VVIR, you instantly know it paces and senses the ventricle, it's inhibited by a native beat, and it's rate responsive. Knowing this code is like having the device's blueprint right in front of you.
And it's the same idea for defibrillators with their own code. But here's something you absolutely have to remember. Pretty much every ICD you'll see today is also a really advanced pacemaker. This code breaks that down. Position 1 tells you which chamber can get that high-energy shock. Position 2 is about anti-tachycardia pacing, or ATP. That's a burst of fast, low-energy pacing to try and stop a tachycardia without a big shock. Position 3 is how it detects the bad rhythm, and Position 4 tells you all about its backup pacing function for slow heart rates.
Okay, listen up, because this is probably one of the biggest points of confusion and one of the most dangerous mistakes you can make: the magnet. Here's the deal. A magnet does not do the same thing to a pacemaker and an ICD. Slap a magnet on most pacemakers, and it goes into a fixed-rate, asynchronous mode. It just paces at a set rate no matter what the patient's heart is doing. But on an ICD, a magnet only turns off the anti-tachycardia therapies. It will not shock the patient. Let me say that again. It does not change the pacing mode. So if your patient is pacemaker dependent and has an ICD, a magnet will not save them if EMI inhibits their pacing. You need reprogramming for that. This difference is absolutely critical.
So, we've got the basics down. Now, let's build on that and walk through the official framework we should all be using. The American Society of Anesthesiologists Protocol for Managing These Patients. This is our playbook.
The work here starts way before the patient even hits the OR. This preoperative evaluation is the foundation for everything. Step 1, simple. Confirm the device is actually there. Step 2, find out what it is. Who made it? Why was it put in? Step 3, and this is huge, are they dependent on it? Does the patient have a survivable underlying rhythm? Step 4, you need that interrogation report. You have to know the current settings and battery status. And finally, Step 5, look at the surgery. Is electromagnetic interference or EMI likely? Because that one question is going to dictate your whole intraoperative.
So what are we talking about when we say EMI? Well, the number one culprit in the operating room is, of course, monopolar electrosurgery, the BOVI. But as you can see, the list is pretty long. We've got radiofrequency ablation, radiation, lithotripsy, even ECT. Just being aware that these are potential troublemakers is the first step to managing the risk. All right, now we're in the OR, and it's all about being vigilant and prepared. First, continuous monitoring is an absolute must. And I don't just mean the ECG. You need a peripheral pulse monitor, like a pulse ox or an art line, running the whole time. The ECG can lie to you during EMI. It might look fine, but the pulse will tell you the truth. Second, you have to actively mitigate EMI sources. Third, if something happens, if you see an interaction, surgery stops. You have to manage the interference. And finally, always be prepared for the worst. If you've altered the device's function, you must have external pacing and defibrillation right there, ready to go. So, what do you actually do when you have to use the BUVI? Well, it's all about physics. The goal is to keep that electrical current path as far away from the generator and the leads as possible. That means carefully placing the dispersive pad or the BUVI pad to create a path that doesn't cross the device. You also want the surgeon to use short, intermittent bursts, not just lean on the pedal. And obviously, if it's an option, using bipolar cautery or a harmonic scalpel is always the safer bet because the electrical field is so much smaller.
The job is not done when the drapes come down. The post-op period is just as critical. Monitoring has to continue in the PACU. That emergency cart with the defibrillator needs to stay with the patient. And here's the most important step. The device has to be interrogated again and restored to its permanent settings before that patient leaves a monitored area. Let me be really clear. Sending a patient to the floor with their ICD therapy still turned off is a huge safety event. It just can't happen.
Okay, theory's one thing, but let's see how this all stacks up in the real world. We're going to dive into our first case study, which focuses on that really common problem of electrosurgery and EMI risk.
This is the question we all ask ourselves, right? We're doing everything by the book, we're following the protocol, but what's the actual risk that something bad is going to happen? Well, a fantastic study by Schulman and his colleagues set out to answer that exact question. So this is the protocol they actually used in the study, and it's a great visual. You can see how strategic the placement of the dispersive pad is. For surgery up on the head and neck, look, the pad is on the opposite shoulder, keeping the current away from the chest. For abdominal surgery, the pads are down on the thighs. This isn't just slapping a pad on anywhere. It's a deliberate plan to minimize the electrical current flowing near that device.
And what do they find? The results are, wow, they're really eye-opening. For any surgery happening below the umbilicus, the risk of a clinically meaningful EMI event was zero. A flat zero. But for surgery above the umbilicus, that risk suddenly jumps to 7%. And in cardiac surgery, it's a whopping 29%.
And this is our teachable moment. This study gives us powerful, hard data that validates the ASA guidelines. A 7% risk is not trivial. That's a real chance of an inappropriate, painful, and hemodynamically significant shock. This is precisely why we use the umbilicus as a critical landmark. The data couldn't be clearer. For surgery with monopolar cautery above that line, you should suspend the ICD's shock therapies.
Okay, let's ramp up the complexity a bit for our second case. Now we're throwing high-risk obstetrics into the mix, which adds all these other layers we have to think about, like the physiology of pregnancy and, of course, the baby.
So meet our patient. She's 33, almost to term, and scheduled for a C-section. And right away, you can see her history is incredibly complex. She has congenital long QT syndrome, a primary electrical problem. She's also had a tetralogy of Fallot repair, which means she has structural heart disease with scar tissue. And because of all this, she has an AICD for secondary prevention, meaning she's already had a major arrhythmic event in the past. This is about as high risk as it gets.
For a patient like this, our anesthetic plan has to be incredibly precise. We're basically walking a tightrope. Goal number 1, keep things calm. No pain, no anxiety, no stress. Any catecholamine surge could be a disaster for her. Goal 2, we've got a C-section, which means electrosurgery above the umbilicus, so we need a rock-solid plan for her AICD. And goal 3, we have to keep both mom and baby stable, which means being super aggressive about preventing and treating any drop in blood pressure that could cause a dangerous reflex tachycardia. And this table just lays out so beautifully how every single choice was made with those specific goals in mind. For the AICD, they followed the protocol perfectly, therapies were turned off by a specialist beforehand, and external defib pads were placed. They chose general anesthesia with an RSI to control the airway and blunt that sympathetic response to intubation. For maintenance, a remifentanil drip is a great choice. It's potent but short-acting, so it's safer for the baby. And here's a really key clinical pearl, the choice of vasopressor. They used phenylephrine. It's a pure alpha agonist, so it raises blood pressure without jacking up the heart rate, which is exactly what you want to avoid in a patient with long QT.
Post-op, that same level of meticulous care continued. She went to a high-dependency unit for close monitoring. They used a multimodal pain plan to keep her comfortable and her sympathetic tone low. And, critically, her AICD was interrogated right away in the recovery room and its life-saving functions were turned back on. And the result of all this incredible, team-based, protocol-driven care, it was a home run. A healthy baby was delivered, and mom remained completely stable with no cardiac issues.
we've gone through a ton of information, from the basic codes all the way to really complex case management. So now, let's just boil it all down to the absolute must-know, practice-changing takeaways that you can integrate into your work tomorrow.
All right, let's lock these 5 points in. Number 1, you have to evaluate every single device every single time. No shortcuts, no assumptions. Number 2, location matters. Use the umbilicus as your line in the sand for EMI risk. 3, magnets are not one-size-fits-all. Burn that different response for pacemakers and ICDs into your brain. 4, plan for failure. Anytime you change a device's function, you must have an external backup right there in the room. And number 5, collaborate. These are team sports. You need to be talking with cardiology, the device reps, and your surgeons. So I'll leave you with this final thought. Based on everything we've talked about today, what is the one concrete step you are going to add to your own preoperative CIED checklist? Because thinking about it and then actually doing it is how we all get better and keep our patients safer. Thanks so much for your time and attention today.